All right, hello, good morning, good afternoon, everyone, and thanks so much for joining us today. In the interest of time, I think we're going to go ahead and get started. So welcome to CHI's HIV Access Program webinar, Paired Pandemics, Ensuring HIV Care Continuity and Market Stability During COVID-19. During this webinar, my colleague Zach and I will be presenting CHI's 2020 HIV Market Overview that is based on our recently published 2020 HIV Market Report, which covers key trends in the HIV space, forecasts of how we expect the market to evolve in the next 5 years, and also touches on how COVID-19 has impacted HIV services. We will then have a panel discussion that will focus on the resiliency of national HIV programs and markets, and how the global community is ensuring HIV care continuity amidst dual pandemics. Throughout the presentation, feel free to type questions into the Q&A box, and we'll address them as time allows. So I'll get us started today with a quick overview of our presentation. The structure of our market report and the bulk of today's presentation follows our HIV strategy of test smart, treat right, and stay negative. Throughout the presentation, we have also highlighted COVID-19 impacts with a blue dotted box like the one at the bottom right of the screen. So keep an eye out for those as we move through the slides. And I'll begin with a few slides on some general HIV market trends. Over the past 5 years, progress has been made toward the 2020 fast track targets. However, the world was already off track to reach these goals by 2020, and the COVID-19 pandemic has created many additional challenges. So as you can see in the graph in the top left, which shows achievement of each 90 target by region, there are considerable gaps between regional progress and the 90s targets. By the end of 2019, only 9 lower and middle income countries had achieved the 2020 fast track targets. However, Eswatini did achieve the 2030 95, 95, 95 targets more than 10 years ahead of schedule. Now, as we turn to the right side of the slide, we've highlighted some of the impacts of the COVID-19 pandemic on HIV services. And these impacts include disruption to supply chains, increased burden on already strained health systems, and restriction of movement, which has made it more difficult for people and goods to reach clinics and hospitals. The chart on the bottom right further shows the number of countries that reported disruptions to different HIV services as of a June 2020 WHO survey. And we're seeing disruptions across the continuum of care, from prevention to treatment to testing. And given these setbacks, it's more critical than ever that HIV services be maintained in the COVID-19 era and beyond. And one of the ways that countries have combated these COVID-19 disruptions is by expediting an ongoing shift to multi-month dispensing, or MMD, to ensure continued access to ARVs. And the benefits of MMD are even more applicable in the COVID-19 era, as it decreases the risk of exposure because patients are visiting clinics less often. And it also reduces the burden on healthcare facilities that are grappling with an influx of COVID-19 patients. 90% of countries surveyed by the WHO have adopted multi-month dispensing, and in many places, access has also been expanded to patient populations that were previously ineligible, such as pregnant and breastfeeding women, children, and TB, HIV co-infected individuals. So looking next to market trends, in generic accessible LMICs, which we define as countries where generic manufacturers supply most of the ARVs, in 2019, we estimate that the ARV market size in GA LMICs was $1.7 billion US. And this is based on weighted average treatment costs and formulations in use in 2019. And this market size has stayed relatively stable since 2017. And this is in part due to the fact that more people living with HIV are being put on treatment, which you can see in the chart on the left. And this has occurred in tandem with decreasing ARV prices. So as you can see in the graph on the right, one of the most relevant examples of this is the cost of TLD, which has decreased by around $10 US per patient per year over the past 3 years. So funding continues to be critical to the success of programs. However, HIV funding and LMICs decreased from $19 billion to $18.6 billion in 2019, which is only about 70% of the total UNAIDS estimated need. Furthermore, reductions in HIV funding relate directly to progress against the epidemic. So as you can see in the chart on the left, in regions where the percent of need funded is higher, such as East and Southern Africa, there has also been greater progress toward the fast track targets. And in regions with a lower percent of need funded, such as West and Central Africa, the percent of people living with HIV who are virally suppressed is much lower. Additionally, the COVID-19 response could potentially affect the funds allocated to HIV programs. So for example, in March 2020, the Global Fund allowed up to 5% of HIV funds to be reallocated for COVID-19 responses. And this was important to allow for rapid COVID-19 response, but long-term diversion of funds could pose a threat to the success of HIV programs. And then a final general trend we'll discuss in this section is the role of community input in decision-making. Over recent years, community advocates have significantly impacted treatment optimization and equity. So in 2018, the Kigali's Women's Meeting addressed the now resolved neural tube defect safety signal and advocated for continued access to DTG for women of childbearing potential. And more recently, in 2020, on the left, during the Kigali community meeting to discuss the implications of weight gain and hypoglycemia associated with certain ARVs, the community again called for informed consent and choice in their treatment options. And this advocacy has helped to safeguard DTG access and ensure that HIV programs can best serve the needs of people living with HIV. I'll now move on to the next section, Test Smart, where I'll outline some major HIV diagnostic trends. In 2020, the COVID-19 pandemic impacted testing services worldwide, with 38 countries reporting disruptions to HIV testing in a June WHO survey. And these reductions are in part due to hampered access to clinics as a result of lockdowns, as well as a reluctance to visit health facilities because of fear of exposure to COVID-19. However, there is some evidence that testing volumes are beginning to rebound. So for example, looking at the chart on the bottom left, you can see the sharp decline in HTS volumes in Kenya between March and April 2020, following the implementation of movement restrictions. However, since then, volumes have been steadily increasing and are now approaching pre-pandemic levels. And similar trends have also been seen across the region, suggesting a rebound following initial drops in testing volumes. So turning now to HIV Soft Testing, the market continues to grow with increased donor support and new suppliers. As of COP fiscal year 2020, PEPFAR will now support facility-based HIV Soft Testing when prices are below $1 US per test. And while there is no current test available at this price, this does represent a signal to the market that lower prices will likely result in increased product demand. There are also now 4 HIV self-tests with WHO pre-qualification, which can be found at the bottom left of this slide. HIV self-testing also represents an opportunity to reduce patient healthcare worker contact during the COVID-19 pandemic. So for example, as you can see in the graph at the bottom, distribution of HIV self-test kits in Eswatini increased during lockdown, which allowed for critical access to HIV testing when movement was restricted. However, this increase in HIV self-testing during lockdown was not seen across all countries. So as we can see in this graph, in this Southern African country, HIV self-testing saw a significant drop following lockdown in March of 2020. And this is in part because several major HIV self-testing distribution centers were closed during the initial lockdown period. But really the primary driver of this decrease is the decline in facility volumes, given the vast majority of distribution of self-testing kits is facility-based. However, as we look to the right side of the graph, you can see that the distribution of self-testing kits increased back to pre-pandemic levels by June 2020. Early infant diagnosis has also been impacted by the COVID-19 pandemic, although thus far it appears to have been disrupted to a lesser extent. So this slide is showing cumulative EID tests in Uganda, Kenya, and Malawi, with increasing EID disruption as you move from left to right. So as you can see in Uganda on the left, 2020 cumulative EID volumes are very similar to 2019 volumes. However, as we look at Malawi on the right, we can see that there has been more disruption in EID samples. Overall, though, across most countries, EID has been prioritized and impacted less by COVID-19. However, even before COVID-19, scale-up of EID has been relatively slow. So in 2019, 1.63 million EID tests were conducted, and you can see in the chart on the right that we project the number of tests to increase to 2.38 million by 2024. Additionally, the WHO is releasing updated guidelines, which include EID and point-of-care EID, and these guidelines are expected to be released in Q1 2021. So I'll now hand it over to Zach, who will present the Treat Right sections.
Thanks so much, Jessica. So as my colleague Jessica Fox mentioned, my name is Zach Panos, and Jessica and I work on CHI's HIV Access program. And I'll start off this section on advanced HIV disease. And would like to start with the chart on the left, showing the number of AIDS-related deaths and the number of PL-HIV on ART over time. Even as the number of PL-HIV on treatment has scaled up considerably from 11.4 million in 2012 to over 25 million in 2019, there were still 700,000 AIDS-related deaths last year in 2019. And of course, all of this is before COVID, and there have been a number of disruptions to advanced HIV disease, or AHD, services as a result. Some of which I've highlighted on the right that come from South Africa, where you can see steep declines in TB, CD4, and cryptococcal antigen testing rates during their strictest level 5 lockdown. And in addition to these testing delays, there have also been a number of procurement delays due to COVID that have delayed country rollout of the WHO's AHD package of care. And in terms of AHD commodities, Over the course of the Untitled Chapter AHD initiative, there have been a flurry of pricing deals and new products that have come to market that have made implementing the WHO AHD package of care easier. This includes the reduction in price of flucytosine from $110 to $75 per pack, and the availability of two suppliers in the market, Mylan and McLeod's. This also includes the pricing agreement for Sanofi's rifapentine and the McLeod's fixed-dose combination of rifapentine and isoniazid for use as 3-HP. However, there have been some quality control issues with these rifapentine-based products recently that have delayed their production and rollout. And finally, Visitech's semi-quantitative, non-device-based CD4 RDT received WHO pre-qualification and is available for under $4 per test ex-works. And as part of the Untitled Chapter Advanced HIV Disease Initiative, catalytic procurement has been initiated in a number of high-burden countries across sub-Saharan Africa, as you can see in the map on the right. And this will enable country programs to gain experience using the product ahead of broader rollout of the package of care, although as mentioned earlier, there have been delays in procurement as a result of COVID. And finally, I want to highlight some of the ongoing clinical trials and new products in development that aim to further improve the diagnosis and treatment of advanced HIV disease. So focusing on cryptococcal meningitis, in the blue box on the left, we've highlighted the AMBITION study, which is looking to see if a single dose of liposomal amphotericin B and 14 days of flucytosine and fluconazole is non-inferior to the current WHO standard of care, which recommends 7 days of amphotericin B deoxycholate, which is poorly tolerated. And on the TB side on the right, Fujifilm is developing a urine-based TB LAM test called FujiLam that is more sensitive than the existing Abbott TB LAM test. However, COVID-19 has delayed the WHO evaluation of this product. And finally, looking at cryptococcal disease on the bottom right, IMI is developing a semi-quantitative lateral flow assay that may negate the need for confirmatory lumbar puncture. And the semi-quantitative nature of this product would allow healthcare workers to stratify patients by antigen level and provide differentiated care. Unfortunately, as with the FujiLam test, COVID has delayed CE marking and potential US FDA approval of IMI's semi-quantitative CRAG LFA. So to move on to the adult market trends, I want to start with a high-level view of COVID's impact on treatment services. And while we know that there have been delays in procurement and shipping of ARVs, for many countries this has not meant major treatment disruptions. And so this chart from UNAIDS shows the number of people on ART each month in select countries, expressed as a ratio relative to January 2020 before COVID. And as you can see, for the countries in sub-Saharan Africa below, with the exception of Zimbabwe in June, the number of patients on treatment have been stable and have increased in Kenya, Botswana, and Lesotho. And in total, of the 22 countries that reported trends data, only 5 showed a decline in the number of people on ART throughout the COVID pandemic. So to look at some data, at the end of 2019, there were 36.2 million adults living with HIV globally, with 24.4 million on treatment for a global coverage rate of about 67%. And over 80% of these adults live in generic accessible LMICs. And in this group, there is a slightly higher coverage rate of around 70%, as you can see in the chart on the bottom left. However, there are some stark regional differences in coverage, as you can see on the right, with West and Central Africa lagging a bit behind East and Southern Africa in terms of adult ART coverage. So what medicines are these patients taking? A large and increasing number of them are taking DTG-based regimens, with over 120 countries, including DTG in their guidelines, and over 6 million patients on TLD. Additionally, a number of countries have transitioned very large numbers of patients to TLD, including the 4 we've called out in the green box, which have each transitioned over 700,000 patients to TLD so far, and South Africa has transitioned approximately 2 million patients to TLD. And on the right, we have CHI's forecast for NNRTIs and INSTIs. And you can see that CHI estimates that 29% of adult first-line patients were on DTG in 2019, with that number expected to exceed 50% by the end of this year and eventually grow to over 90%. And while it's not on the slide, I want to highlight that 10 manufacturers have either US FDA or WHO pre-qualification for TLD products, which represents a very robust supply base. Shifting gears to NRTIs, unsurprisingly, as TLD scales up, we are seeing TDF share of first-line NRTIs increase with a market share over 90% in 2019. And countries are still considering the place of TAF, especially amidst the emerging data on weight gain. And we think there is the potential for TAF to play a larger role in treatment, and our forecast here assumes that TAF becomes the alternative regimen in the WHO guidelines. However, its place ultimately remains to be seen, as more data is needed on weight gain and in other important populations, such as pregnant women and people who are co-infected with TB. Botswana, Zambia, and Zimbabwe have become early adopters of TAF, and the box on the right highlights some information on Zambia's introduction, which includes their target populations of children over 25 kilograms and adults with renal failure, and their participation in active pharmacovigilance to monitor for adverse events such as weight gain, hyperglycemia, and rashes. And moving on to second line, the graph on the left shows the second line protease inhibitor market share for a few select years since 2012. And as you can see, ATVR's share of second line has continued to increase and reached approximately 42% in 2019. We also know that shortages of lopinavir/ritonavir earlier this year resulted in many patients being proactively switched to DTG or ATVR in second line. And so we expect lopinavir's second line market share to decrease significantly in 2020. Countries are beginning to eye the use of DTG in second line as they wrap up their first line transitions to TLD, and DTG would offer both clinical and financial benefits over lopinavir/ritonavir. And we have seen some countries begin to proactively shift existing second line patients on protease inhibitors to DTG. And I also want to discuss deravarine/ritonavir, which is a superior protease inhibitor with a high genetic barrier to resistance. And although it's primarily used in third line now, it will likely play a role in second line treatment if an affordable generic fixed dose combination of deravarine and ritonavir is approved, which is something that Chai and Unitaid continue to work on. And finally, to close out the adult section, I want to highlight a few products that have recently been approved, as well as some products in the pipeline. So in terms of recent approvals, on the left in blue, the two-drug combination of dolutegravir and lamivudine from ViiV has received US FDA approval for use in both treatment-experienced and treatment-naive patients. However, some questions remain about the use of two-drug regimens in the LMIC setting. ViiV had another drug recently approved, Fostemsavir, which is the first-in-class attachment inhibitor and has been indicated for use in heavily treatment-experienced PL-HIV. And a note on a product that is not on the slide is Deravarine, which is produced by Merck. And although there is no generic currently available, it could be a potential option as an efavirenz alternative for patients who are unable or do not wish to take DTG. And as for products still in the pipeline, on the right in green, the US FDA declined to approve ViiV and Janssen's injectable cabotegravir rilpivirine for treatment last year due to concerns with chemistry and manufacturing controls. ViiV resubmitted their dossier to the US FDA in July and expect a decision in early 2021. Although I do want to call out that both Health Canada and the EMA have approved this product this year in 2020. And finally, I want to quickly mention Izlatravir, the first ever non-nucleoside reverse transcriptase translocation inhibitor, or NRTTI, which has a very high potency and long half-life. And it's under consideration for both treatment and oral PrEP and has the potential to be dosed less frequently than daily, given its long half-life. So to move into some pediatric market trends, here I'm showing some similar information to what we showed for adults. And at the gray bar across the top, in 2019, there were 1.8 million children living with HIV globally, with 960,000 on ART for a coverage rate of about 53%. And of all these children on treatment, 95% live in generic accessible LMICs. And the graph on the bottom left shows the historical number of pediatric patients on treatment, as well as two different forecasts. The purplish blue forecast is the status quo, which based on past trends shows that the number of kids on treatment is expected to be relatively flat over the next 5 years, although as you can see, coverage increases as more children age into the adult cohort. The green bars show what the forecast could look like if there was just a 5% year-on-year increase in the number of children put on treatment, which would get coverage closer to 90% by 2024. But to go beyond the status quo and achieve this green forecast, we have to improve case finding, decrease loss to follow-up, and decrease mortality. And in terms of the medicines these kids are taking, in 2019 and 2020, we saw a continued focus on optimization as nevirapine is phased out and abacavir replaces zidovudine in the backbone. The graph on the left shows procurement volumes of key pediatric products as seen via the APWG. And you can see the steep decline in packs of AZT3TC nevirapine or ZLN in orange, while there has been a subsequent increase in the procurement of lopinavir/ritonavir and abacavir-based regimens over the same time frame. However, this is procurement, which we know can lag behind implementation, and the charts on the right show what drugs kids are actually taking. The top shows which NRTIs are in use, and you can see that Izlatravir is decreasing, or its market share is decreasing as Abacavir continues to be scaled up. And on the bottom, which shows NNRTIs, PIs, and integrase inhibitors, you can see that nevirapine continues to decrease, and we expect this number to drop precipitously in 2020 as countries use up their remaining stocks of nevirapine with no intention to refill them. And to continue this discussion on optimization, I want to spend some time talking about pediatric DTG 10 milligram dispersible tablets. And as I think we all know, the WHO lists dolutegravir as the preferred drug for children and adults, but there is currently no approved generic formulation for children under 20 kilograms. However, both Mylan and Macleods, with the support of ViiV, Chai, and Unitaid, are developing DTG 10 milligram dispersible and scored tablets, which will allow for DTG to be used in children between 3 and 20 kilograms. And we expect the first approval of this product to come this quarter, with in-country availability likely starting in Q2 of next year and increasing by Q3. And just a note on the lopinavir-ritonavir-based products, including pellets, granules, and the potential 4-in-1, these will still be important, but will likely play a decreasing role as children are transitioned to DTG. And finally, although I know the community is excited about DTG 10 milligrams, this slide highlights a few products that are still a few years away from being available in LMICs. And in particular, I want to highlight pediatric Deravarine-ritonavir in the middle in green. And similar to adults, Deravarine-ritonavir is a best-in-class protease inhibitor with a likely use case among children failing DTG-based therapies. However, high costs and a relatively small market size have been barriers to development. And to address this, Chai and Unitaid have launched an RFP in September of this year to work with manufacturers to develop this product. And to close out the pediatric section, I want to end with a quote from the WHO on the importance of transitioning pediatric patients to optimal regimens now and not waiting for new products to be approved. And now to close out the Treat Right section, looking at appropriate treatment monitoring. And so given the COVID-19 pandemic, we wanted to look at how it's impacted viral load volumes. And here we're showing a very similar slide to what Jessica showed for EID, showing viral load volumes in Uganda, Malawi, and Kenya from January to September for both, or to October rather, for both 2019 and 2020. And you can see the charts are ordered from left to right in terms of increasing viral load testing disruption, with relatively little disruption in Uganda on the left, except for a slight decrease in the summer. On the other hand, as you can see with Kenya on the right, there has been significantly fewer viral load tests run in 2020 so far compared to the same time last year. And if we zoom in on Kenya a bit, you can see that by the end of October, there were about 300,000 fewer viral load tests run than in 2019, for a decrease of about 22%. And like many countries, Kenya issued guidance to rationalize services amidst the pandemic, and NASCOP issued a circular in March to help reduce the volume of patients and specimens at testing sites. And the three populations prioritized for testing were pregnant and breastfeeding women, newly diagnosed patients, and early infant diagnosis. And finally, we've produced similar global forecasts for viral load and CD4 testing as we have for EID, both of which feature a level of uncertainty for tests run in 2020 due to COVID. And for viral load, I'd like to call out that we estimate that over 20 million viral load tests were run in 2019, which is very exciting and a testament to the effort of everyone on this call and countless others to expand access to viral load testing globally. And for CD4 on the right, although we expect CD4 testing to decrease over time, it will still be a critical service to identify patients with advanced HIV disease, and so will still have a place within national testing programs. And with that, I'll pass it over to Jessica.
Great, thanks so much, Zach. So in this next section, I'll highlight some of the major trends in the HIV prevention space. In 2019, the number of new annual HIV infections remained stagnant at 1.7 million. However, the share of infections among key populations and their partners continues to increase. So as you can see in the graph on the left, the number of new infections has been decreasing since 2010. However, there was no change in the number of new annual infections between 2018 and 2019. Additionally, as the chart on the right shows, key populations and their partners account for more than half of new infections and need to remain a focus of prevention interventions. Oral PrEP, a highly effective HIV prevention method, has seen increasing adoption across countries. And as of October 2020, there were over 770,000 cumulative oral PrEP initiations globally, and almost 60% of these were in LMICs. As a result of COVID-19, while there were some disturbances in oral PrEP initiations at the facility and even the country level, aggregate initiations across LMICs saw a pretty steady month-on-month increase, as shown in the graph at the bottom left. New evidence has also continued to demonstrate the effectiveness of oral PrEP. Data from the SEARCH study in Kenya and Uganda found that oral PrEP prevented an estimated 3/4 of HIV infections in people within the study population at high risk of HIV. And this is the largest reduction in HIV infections yet reported in an oral PrEP study in sub-Saharan Africa. Data from the ECHO study in South Africa also found a 55% reduction in HIV incidence, and this was found across all participants, whether or not they themselves took oral PrEP. Additionally, recently released data from the HVTN 084 study, which I'll talk about more shortly, showed a higher than expected level of adherence to TDF-FTC throughout the study, as well as an overall low incidence rate in both arms of the study, clearly demonstrating that both drugs were highly effective at preventing HIV acquisition. Finally, here we also want to highlight that a new formulation of oral PrEP, TAF-FTC, has been approved by the US FDA for use as oral PrEP excluding cisgender women and others at risk from receptive vaginal sex. And a clinical trial for cisgender women and adolescent girls is expected to be completed by 2024. There are some additional considerations, which we've highlighted on this slide, including lack of generic formulation and cost limitations. So moving next to voluntary medical male circumcision, or VMMC, a one-time highly cost-effective intervention that reduces the risk of HIV infection. Like many other services we've discussed during this presentation, VMMC has been impacted by the COVID-19 pandemic, in part as a result of its heavy reliance on outreach models. So you can see this disruption in the graph on the right, where several Southern African countries saw reductions in VMMC performance in 2020 compared to previous years. And looking toward upcoming prevention products, this year, updated results from the HVTN 083 clinical trial found that cabotegravir long-acting, or CAB-LA, injectable PrEP is superior to daily oral TDF-FTC for cisgender men and transgender women who have sex with men. And some exciting and very recently released results from the HVTN 084 trial, which is collecting data on cisgender women, found that CAB-LA is superior to daily oral TDF-FTC for cisgender women as well. However, a number of milestones are required before product introduction, including regulatory approval, development of normative guidance, and integration of optimal delivery channels. And the Biomedical Prevention Implementation Collaborative, or BioPIC, aims to support accelerated product introduction for CAB-LA for prevention by planning in parallel to clinical trials and by coordinating stakeholders to ensure projects are well designed to provide evidence to quickly build from small pilots to scale. Finally, I'll quickly highlight a couple additional pipeline prevention products. First, the Deravarine, or DPV, vaginal ring received a positive conditional scientific opinion by the European Medicines Agency. However, clinical research has found the ring only reduced HIV risk by 30 to 35%, and the EMA emphasized that it should only be used when oral PrEP cannot be used or is not available. Also highlighted on the right side of the slide, a number of multi-purpose prevention technologies, or MPTs, are in development, which are designed to deliver varied combinations of HIV, STI prevention, and contraception. And this streamlined delivery could increase uptake across forms of protection, resulting in fewer HIV infections, other STIs, and unintended pregnancies. So to conclude, I'll just provide a quick summary of some of the key takeaways from this presentation. In the Test Smart bucket on the left, we have seen decreases in testing volumes following lockdowns, but there is some evidence that rebound is starting to occur. Some places have used HIV Soft Testing to ensure continued access to testing, but this has not been the case everywhere. And while there were some COVID-related disruptions in EID, many countries prioritized this critical service. Looking next to Treat Right in the middle, multi-month dispensing has been expedited to ensure continuity of care in the COVID era. And there have been a number of delays in procurement, particularly for AHD commodities. However, overall, treatment services have experienced less disruption than initially feared, although there have been a number of disruptions, particularly in viral load monitoring. And then finally, in the Stay Negative section, oral PrEP initiations have stayed relatively stable throughout 2020. However, VMMC services have been disrupted in a number of countries in Southern Africa. I'd also like to acknowledge our funders for supporting our work in the HIV space. Thank you for your time and attention. I'll now pass it over to Carolina Mole to kick off the panel discussion.
Great, thanks so much, Jessica. And if you could just advance to the next slide. Perfect. So hi, everyone. My name is Carolyn Amel, and I lead our HIV program at CHI. We are so grateful that so many of you have joined us today, and I'm excited to kick off our panel discussion now. Before I do that, though, thanks so much to Zach and Jessica for leading us through the presentation. For those in the audience, if you have any questions about the presentation, please just type those questions directly in the Q&A box. Zach and Jessica are standing by to answer those. So now we've got a fantastic panel for you today, and I'll just ask my panelists to come on video, please. Our panelists cover a number of different perspectives, from the community to the Ministry of Health, to donors, to the WHO. We'll talk about how we are ensuring resilience of HIV programs during the time of COVID, and we'll also reflect on what we have learned from HIV and applied to the COVID response. I have a number of questions for our panelists, but if any of you also have questions for the panelists, please put those in the Q&A box. Just indicate it's a question for panelists, and as time permits, I will ask those during the next little less than 30 minutes. Before I kick off our discussion with some questions, first I'd just like to introduce the panelist. So Dr. Eleanor Magongo is a pediatrician and child health specialist with 13 years experience leading teams to design, implement, monitor, and evaluate pediatric and adolescent HIV programs. Eleanor works at the Ministry of Health AIDS Control Program in Uganda, where she leads the National Pediatric and Adolescent HIV Program and is currently leading the Pediatric and Adolescent ART optimization process in the country. Next, most of us know Dr. Laura Voinov as the Diagnostics Advisor in the Global HIV, Hepatitis, and STI Program at the World Health Organization. Since April, though, she has also been seconded to the Health Emergencies Department at the WHO to lead the diagnostic supply team within the COVID response. Next, Carmen Perez-Casas is the Senior Strategy Manager at Unitaid, focused on identifying new strategic interventions for Unitaid to support that can overcome barriers for access of innovative medicines, diagnostics, and preventive tools. Carmen's career has been focused in global health, and in particular on access to health products in low and middle income countries. She worked at MSF, the Global Fund, and as a consultant for various international institutions prior to joining Unitaid. Next, Kinley Sekweze is director of the AfroCAB network. He's based out of Lusaka and a member of the Unitaid board. He has been a member of several global HIV treatment access processes, including WHO HIV treatment guidelines. Kinley co-chaired the UNAIDS 90-90-90 retargeting process, and is a member of various advisory committees, too many to name. Kinley is also a regular speaker and community advocacy mentor on widening Africa's access to the best available HIV and other treatments. And then lastly, Cathal Mir is a sourcing manager with a global fund responsible for the pharma sourcing category. He joined the organization recently in June 2020 from the private sector. His last position was with Novartis, where he worked as a supplier relationship manager with a focus on building and improving partnerships with strategic external contract manufacturers. We have so much expertise here, and I'm excited to jump in. I'll start off with the first question to Laura from WHO. So Laura, in a WHO survey conducted in June, looking at COVID-19 disruptions to HIV, hepatitis, and STI care, disruptions to HIV testing and viral load monitoring topped that list. We also highlighted some of these disruptions in the presentation today. So a two-part question for you. First, what advice do you have for country programs to ensure prioritization of critical HIV diagnostic services? And then secondly, what steps is WHO taking, looking at both supply and demand sides, to support national HIV laboratory programs during this time?
Great, thanks so much, Carolyn, and thanks for having us on the webinar today. We really appreciate being able to contribute to this important conversation. I think in terms of the COVID disruptions, one of the key pieces that the team here has really tried to ensure is that while we really appreciate the ability to leverage the lab networks that have been put in place from both the HIV and the TB systems, and in a number of countries, particularly in sub-Saharan Africa, that's been really critical in order to support the COVID response. Your data has really nicely shown that we have seen some of these disruptions. Fortunately, like you said, on the infant diagnosis piece, we're starting to see some rebounding. But really, I think we also need to be reframing it a little bit on understanding whether we're going back to pre-COVID levels, when really we should be thinking about needing to continue to scale up some of these services. Of course, just simply going back to what we used to be doing was not necessarily some of our goals entering 2020. And so really, you know, we've seen some of the disruptions across a number of different criteria and considerations. And probably the biggest one, and I think there are a number of folks on the call that can speak more to this, but we're really seeing a fair amount on the demand side. And that's caused by some of the lockdowns, some of the reprioritization of staff, of services in healthcare facilities and across the programs. But of course, also some on the supply side, particularly for malaria and some of the other diseases. One of the key pieces on the diagnostics disruptions that we have observed are actually in the laboratory. We've seen a number of repurposing of reagents within infant diagnosis as well as viral load and others, when perhaps some of the components for COVID testing are running short, and they utilize some of the HIV components to try and support that. Of course, as well on the HR side, and prioritizing COVID testing over any of the others. And I think, and this is something that the WHO, the Health Emergencies Team, and comes from Dr. Mike Ryan himself regularly, is really trying to encourage countries to think about how we can support the COVID response, but at the same time make sure that we're ensuring continual efforts and care and services for HIV, malaria, and TB services as well. I think we're very acutely aware, and he's very acutely aware in particular, of the morbidity and mortality that's associated with those, and just really wanting to encourage creative, innovative thinking in terms of how to ensure some of the case finding that might need to happen for HIV testing. And I know Cheryl from our team has some ideas and some guidance there. As well as for infant diagnosis, and then of course continuing monitoring. And I think we'd be very keen to hear from countries as to what some of those efforts have been to try to ensure some of those creative applications and creative case finding during this time. Of course, and community outreach is one of the critical considerations within that. And I know that Cheryl and their team is really thinking about how to utilize self-testing during this time when perhaps facility attendance is not as reliable. I think in terms of your second question, in terms of what are some of the steps that we're taking, we've been very actively involved in a couple of different consortium, one on the side of the COVID around the supply, as well as the Integrated Diagnostics Consortium, where we're working really closely with partners. Number one, trying to think about some guidance to programs, to HIV, TB, as well as emergencies programs in order to think about how we can work together through integration, but also prioritization, ensuring we're meeting the needs of all of those, as well as how we can have a common, unique voice with suppliers when we have seen or do see some of the supply challenges that have come about. And I think this is in particular for some of the other diseases, perhaps in particular on the malaria side, but we are starting to see some potential delays in terms of suppliers being able to provide the HIV products in a timely fashion, really trying to make sure that we speak with one voice to influence that and ensure that products can continue to be provided.
Thanks so much, Laura. So turning from the global normative perspective now to the country perspective, I've got a question for Dr. Eleanor. Uganda has often been an early mover when it comes to new products, and as you well know, new product introduction is of course a challenge, even without a novel pandemic, adding complexity at every step along the way. So with the upcoming approval of DTG 10 milligram for pediatric patients and an anticipated catalytic procurement in Uganda, how is the Ministry of Health working to ensure a swift and successful introduction of this optimal product amidst and despite all of the challenges posed by COVID-19?
Thank you very much for the question, a very pertinent question. So one of the things that we've been able to do in Uganda is to work around our policy framework to ensure that we have dolutegravir included in our guidelines, even for children weighing less than 20 kilograms. So right now, our guidelines have dolutegravir as the preferred anchor drug right from first line, second line. So we have our policy already set. Secondly, to develop tools to support healthcare providers to be able to offer the drug when it's available. We have developed SOPs because we are actually currently in our last phase of optimization, moving Tirelessly for children weighing up above 20 kilograms. And through that, we've been able to develop SOPs that will also be used when we receive Deravarine 10 milligrams. So we've developed SOPs that are simple for healthcare providers to use. We've developed ART optimization stickers, and we've also come up with a line listing tool that is able to support us to track patients all through their viral load cascade until that point when they're suppressed and they are able to be transitioned to optimal treatment. Next, we've also been able to have coordination and accountability meetings. As I mentioned, we are in our final stage of moving all patients from NNRTIs. So we have partner accountability meetings every week on Wednesday.
Dr. Eleanor, we're losing you a bit. I wonder if it's the video eating up your bandwidth. You might just want to turn off video for a minute.
Comes, DTG at 10 milligrams. Sorry, I have kept my video off because I'm afraid my internet connection. So pardon me for that.
That's okay. Dr. Eleanor, sorry.
We also are doing forecasting next week. We are having a large meeting where we are doing forecasting for our commodities.
I think she dropped, Carolyn.
Okay. We'll come back to her when she's back. Sorry about that. So turning now to a donor perspective, I've got a question for Carmen. Carmen, Untitled has been very actively involved in the global COVID-19 response, including co-convening the Therapeutics Partnership under the Access to COVID-19 Tools, or ACT, Accelerator. Of course, in addition to supporting the COVID-19 response, Untitled also funds a number of global health projects that have been impacted by COVID-19. So I'd be interested to hear from you in working with partners and grantees. Does Untitled have any lessons learned from projects that have been able to minimize the impact of COVID-19?
Yes, thank you, Caroline, and good afternoon to everybody. So yes, we are indeed, and since right the beginning of the epidemic by working with different partners, we immediately try to repurpose and leverage the work we have with partners to address some of the main COVID emergencies or gaps, let's say, including from distribution of oxygen diagnostics to leveraging the community work, and of course supporting the research on people living with HIV and COVID. But indeed, very soon as well, we were trying to see how to actually minimize the risk of COVID to the main core work on HIV, on malaria, on tuberculosis, etc., that we support with partners. And through that, there are indeed a number of lessons learned and innovations that we wanted to share with you, and that actually have been reviewed with partners this very week in an implementer forum.
I think it has come back, but let me try. Okay, you read for me.
Please use the small amount of time perhaps with Wi-Fi connection to hear from Uganda again.
Just mute myself.
Hi, Dr. Eleanor, just give us, I'm going to come back to you in 1 minute We just moved over to a question from Carmen, but I'll come right back to you.
So in a nutshell, actually, the disruptions of COVID in our projects have been mitigated by, I will say, three kind of big buckets of interventions. On the one hand, simplification and patient-centered approach or measures, then making use of digital technologies and ensuring the greatest outreach and community involvement. Some of the lessons we have heard and examples in these three areas could be starting by simplification, the multi-month dispensing that you have already covered in the wonderful presentation we just heard, and that has also been implemented in our projects, including with CHAI, but also the PrEP programs that we, for example, support in Latin America and in South Africa have been making use of this multi-month dispensing as well for PrEP, which is very important. And I wonder if we could actually discuss that for children as well, which could be a very important way. Continuing on the human and person-centered approaches, we believe also self-testing has, of course, been very important. It was already taking some speed, as you have shown in the presentation, but also, again, have been very important on continuity of services on pre-exposure prophylaxis, dispensing the self-test kits for monitoring via mail or courier, for example. And also in self-care, there is the self-collection of samples from other kind of diagnostic tools that have been very important, including in the projects with CHAI, the community-based self-sampling for viral load, but also for cervical cancer screening, for example, in terms of co-infections. And also the mobile van laboratories, the use of pharmacies, and other ways to get closer to the community in terms of diagnostics. And as one of the implementers called actually in our forum for the nurses at the front theme, we believe indeed that task shifting is very important, but can only be enabled if the tools are simplified. So if we get more easy to use tools, otherwise will only be an overburden to the lower part of the chain. So on the second bucket regarding telemedicine, of course, e-health, mHealth, they are being, not surprisingly, super important on mitigating the effects of COVID. On the one hand, for the implementation of our clinical trials on antiretrovirals, where it has been really key to have the possibility on remotely managing the data collection and management, but also for maintenance of service delivery. So our partners working with PrEP again, were able to do clinical monitoring, counseling, and peer support for PrEP clients remotely. And also it was not regulated, but then it was eventually accepted in countries like Brazil. And it has also been used, of course, for HIV testing and for linking with HIV positive individuals into care. But none of this, as I said, could have been possible with more complicated tools, but also without community support. So public health messaging and peer-led materials, but many other ways to support the community involvement have been key in applying these innovative approaches or solutions. Thank you.
Thank you so much, Carmen. And I'll come back to the community perspective. I'm really glad you raised that in 1 minute. But first, Dr. Eleanor, if we still have you, I just wanted to turn back to you so that you could conclude your comments from earlier when we lost you.
Thank you very much. I hope you can hear me better. I've been able to switch to a different internet connection.
Much better. Yes, thank you so much.
Thank you so much. I'll quickly go through what I had mentioned earlier, but I'll be very brief. So I mentioned that in Uganda, we already have a policy framework that supports the introduction of dolutegravir at 10 milligrams because we've already included dolutegravir as our preferred anchor drug for all patients living with HIV, irrespective of the age and the treatment line. Secondly, we've also developed tools to support healthcare providers to be able to do this process when the formulation comes into the country. And as I mentioned, we already are transitioning children from NNRTIs to optimal treatment like dolutegravir. Currently, we have the 50 milligram tablet. So there are already SOPs in place that have included the fact that when the DTG 10 milligrams arrives, health workers will be able to move the children to a DTG. And as I mentioned before I went off, that even for children who are stable on LPVR, we'll be moving them to dolutegravir 10 milligrams. We also have coordination and partner accountability meetings where we present our weekly optimization process. So when dolutegravir 10 milligrams gets into the country, these meetings are already in place. We will continue to have our healthcare providers present on a weekly basis how they are making this transition, moving children to DTG 10 milligrams. And at that point, we hope that no child will be on nevirapine or efavirenz. So we'll be working towards moving children from LPVR to dolutegravir 10 milligrams. Starting on Monday, we have our forecasting meeting that leads into our procurement process. And in the forecasting meeting, our plan is to incorporate the procurement of dolutegravir 10 milligrams. So again, we are really ensuring that even in our planning for the next consignment of drugs, dolutegravir will be included. And we also have a monitoring system that is going to help us track this process in addition to the partner accountability meetings. That is the PEPFAR surge dashboard, where we've been able to include the ART optimization indicators for children and adolescents. We have also incorporated in our capacity building curriculum the fact that we are expecting this commodity, and right now, this week, tomorrow we'll be concluding, we are concluding the training today, and we've been preparing the national trainers about the same. We have also a national quality improvement project, Pediatric Collaborative, that is again focusing on ensuring that children are being transitioned to the preferred regimen. So again, as the quality improvement is ongoing, when this commodity comes, it is going to find a framework of quality improvement to ensure that children are transitioned to DTG 10 milligrams for those under 20 kilograms who are currently not accessing the commodity. And lastly, we are establishing a cohort where we'll be tracking children longitudinally, and we are doing this with several partners like WHO, CIPHER, the UCL Penta team. And through this cohort, and also working with the CHI team, we are going to be able to monitor the pharmacovigilance to this new commodity. So as a country, we are well prepared to receive this catalytic consignment of DTG 10 milligrams. Thank you very much.
Thank you so much, Dr. Eleanor. It's a really exciting update related to pediatric DTG for Uganda. So thank you so much. Shifting gears a bit now to the community perspective, Kenley, a question for you. And it's a really broad question, but from an advocacy perspective, what lessons has the community of people living with HIV learned over the years in the fight against HIV that should be applied now, or are maybe lessons that are being applied in the fight against COVID?
Thanks, Caroline. I am going to keep my video off so I can gain some bandwidth and not break off. Thank you very much for the invitation. But I think people living with HIV or the community response to HIV has always been and was especially instrumental at the beginning of the pandemic in the 80s and 90s in really leading the way of how to care for people that needed such detailed hospice type or some kind of clinical care where we're dealing with no treatments, no no medicines at all. This is going back pre-ARV, and even after ARVs of course came, as you know, we've led the way in the way we respond to the pandemic and ensure that people achieve virus suppression and gain as much quality of life as possible from an effective treatment regimen. But what we are seeing, I think one of the challenges we're seeing with the COVID response is while we've gained all this knowledge with the HIV, I think one of the immediate things we've noticed is that, the COVID response is being, at country level, is being led by a different set of groups of people leading infectious diseases and not necessarily our HIV experts. And so there is that small disconnect already with, in a way it's being delivered. And that is impacting the response in general, in that there's very little awareness in my country. For instance, it's not unusual to hear people say, COVID is not an African disease. COVID is, is being exaggerated. COVID is only for a certain group of people and not, all kinds of things, because there really hasn't been that community connection that can raise awareness and sensitize the community as to, the seriousness and, the dire need to take the necessary precautions that has been provided, to prevent infections. And so I think one of the things we definitely can bring is be able to raise that awareness, and also being able to mentor some of our colleagues who have survived COVID, the COVID long survivors, I think they're called. I remember just a couple of weeks ago, we had an Africa webinar where we were trying to address these issues of COVID. And one of our community speakers, just having her on that webinar, literally sent all of us to tears. And, we were able to understand in a lot more sort of personal sense, but the seriousness of the disease, that even after you get infected and do recover, the debilitating effects that it can have on your life for a long period of time. And so making these connections with people with long COVID is so critical. And we, and I think learning and using our experience in HIV response as communities, we're able to try and navigate and help them navigate how to use that experience to, support those with COVID or to help bring prevention messages. But I think that connection with our policy and health delivery systems is very important, and I think that is still lacking. And I think we can definitely provide some guidance in that respect.
Thank you so much, Kenley. Incredibly useful perspective. And turning now, and probably to my last question, turning to Cathal for a donor and procurement perspective from the Global Fund. So COVID-19's disruption of supply chains impacted everything, as we all know, from toilet paper to food, and concerns about HIV supply chains have garnered significant interest. Much of the disruption in India and China that initially impacted HIV supply chains has since improved over the past number of months, but there's always the additional risk of, of additional waves of COVID-19 that could bring fresh challenges. So interested to hear how the Global Fund has adapted to become more resilient, and how can the global community help to minimize disruptions in the supply chains of critical health products?
Great, thanks, Carolyn. I think is my sound okay?
Great.
Great, thank you. And thanks also for the opportunity to join today's panel and listen in on some very interesting discussions. And I resonate a lot with what was said by the other members of the panel in different areas. 2020 has been a very challenging year, absolutely, for the industry as a whole, for the pharma industry as a whole. And as you rightly mentioned, we've seen in the last weeks an improvement in the initial challenges we faced in supply chains. In fact, before I get into a little bit more detail about what we're going to do, and I'm wary of time, so I'll be fast about this, is I think that our thanks go out on a regular basis to our suppliers in the interactions with them, and we have that now. It's one of the things that we've implemented as part of the reply to the COVID challenges, as well as regular weekly, if not bi-weekly meetings with suppliers, in particular during the very difficult phases, to see how they were dealing and how we can support them to deal with the challenges they were facing. So I think that they've been able to step up amazingly well when we look at what China initially faced in the beginning of the year, and India then later on, and even now, to see how the pharma industry was able to deal with that as well, and to continue to supply, even if there were delays and there were setbacks as well, and still ongoing as well. But we're seeing, I think, in the ARV in the last few weeks, manufacturing capacity back up to 80 to 90%, which is amazing considering how the lockdown and the impact on India and China were. That said, 2020 has been also a year of learning as well. What it's done is shone the light a lot on the robustness of international supply chains, and that's something that we're going to be looking at a lot more closely in the near future, or going forward with our suppliers, to see what areas have shown weaknesses in the supply chain, and testing the robustness of supply chains or existing supply chains across the world. In particular, what we look at very closely in the coming weeks and months and rolling into 2021 is a closer look at upstream and downstream supply chains to identify risks in those areas, and in particular around key starting materials, the sourcing strategies associated with that, API strategies, encouraging suppliers to look at their strategies, including vertical integration, external sources, and cross-geographic supply chains. So not having all your eggs in one basket, if you like. But not, and this is something we've been working with them already. We've worked with them, I think, in the last few years as well in the Global Fund and with other partners as well around APIs. But we're going to take that a step further as well and look at key starting materials as well. So where are they coming from as well, and what risk mitigation strategies do they have in place? We also intend to look at what we've been particularly noticeable has been, for example, transportation modes and how we speed up from pickup of a product at the supplier, where in some cases the supplier is no longer responsible for the supply chain afterwards, and to the point where the drug product or the finished dosage form is in country, and transportation modes, how we can speed that up, how we have backup plans in place as well, which is something we faced at the very beginning of the pandemic as well, where commercial flights, for example, were closing down, and we were struggling to find alternative routes. But all the way down to packaging, which is a continuing bottleneck for us as well, and the QA release strategy. So we're seeing production capacity where suppliers were able to bring in second and third shifts, even if there was a reduced output. They had backup strategies in place for that. But we were then running into issues during packaging, and we're running into issues when capacity in QA release was down. Another important point we look at is of course demand going forward, and the demand verification process. And this is something I think where we will work even more closely with our partners, and both all the buyers and the suppliers as well, to better understand that and ensure that we're not oversupplying products in areas where there might not necessarily be an immediate impact, and then so channeling those products then to other areas. So this is something that we're implementing now to ensure that we do have that in place for the future in case such a pandemic. We're hoping, of course, that 2021 will continue to improve as we come out of 2020, but if not, that we've learned from what's happened in 2020 and are building on those strategies then together with suppliers and partners for 2021 and for the future.
Excellent. Thank you so much, Cathal. Thank you to all of our panelists. We've reached the top of the hour. I think we could likely continue this discussion for another hour, but we know everybody has to run. A huge thanks to the panelists. Thanks to Zach and Jessica for the presentation. If anybody has any additional questions, please don't hesitate just to send them via email. And thanks so much to all of our many attendees on the call today as well. I hope that the discussion was useful, and we look forward to continuing it in the future. Thank you all so much.